Good afternoon, everybody. Hopefully you all know that my name is Ruth Bailey. I'm a non-executive member and I am chair of today's board. Can I remind everybody that the meeting is being broadcast online and recorded. The recording will be uploaded onto the ICB website after the meeting. British Sign Language will be available on the website. Can members remember to use your microphones when you speak for the benefit of people at the meeting as well as the recording? A hearing loop is available should anyone need to access it. Can I remind everybody that this is a meeting which is being held in public but not a public meeting. We're not expecting any fire alarm tests today, so if the alarm does sound, we will leave through the room through the emergency exits marked in the room. We'll do our best to avoid jargon and acronyms, but a glossary of terms is available on the ICB website and included on the chairs for members of the public observing the meeting today. Questions from members of the public will be taken at the end of the meeting, and one of the team will make a roving microphone available at that time. We've received apologies from a couple of people, so Jacqueline Totterdale, partner member for Acute Services, James Blythe, place member for Sutton, Martin Spencer, non-executive member, and Simon Breeze, the voluntary sector representative. And with no further apologies, the meeting is quorate. Moving on to item 2, declarations of interest. So a register of declared interest is included in the pack of papers. Members are asked to declare any additional interest not already on the register of declared interest included in the pack of the papers, and to declare any interests arising from the agenda or the papers presented for the meeting today. Are there any additional declarations that people wish to make? No further declarations, so we'll just note the declarations in the pack of papers. Item 3, minutes, action log and matters arising. The minutes of the previous meeting, which was held on the 17th of October 2022, are included for approval. Does anyone have any comments on the minutes that were attached in the pack of papers? No. So the board approved the minutes. Oh, Steve, Matthew? No. Just testing the microphone. Okay, so the minutes are approved from the last meeting. The action log has been updated to reflect the latest position on any open actions. Any questions or comments on the actions? No, thank you. So, moving on to item 4, Chief Executive Officer's report. Sarah, I'll ask you to speak to this item.
Thank you very much, Chair. So just a few items on my report. Firstly, you may have seen the media coverage of Bill Kirkup's report, Reading the Signals, Maternity and Neonatal Services in East Kent. I just wanted to assure the board that we are looking at this across South West London, both from a provider's perspective and at South West London level, to make sure that any recommendations from that report are taken up throughout our maternity services, and we will bring a full report on maternity services to the January public meeting, so we will be bringing that forward. Secondly, Black History Month. We've been doing a lot of work across South West London. We are fully committed as an ICB and ICS to diversity and inclusion within both our staff groupings, but also within how we support our local populations. And we've had a programme of events that have taken place with our staff, and we've had some fantastic stories actually, and I think that we want to continue this. This is not just about a month, this is about how we treat all of our staff over, throughout the year. So I just wanted to raise that. You will have seen that there is possible NHS industrial action. Actually, the RCN, the Royal College of Nursing, has, for some of our providers, voted for strike action, not in all of our providers, but in some of them. And we are working with those providers, and we are doing some tests around making sure that we can support mutual aid and manage emergency services in particular across the whole of South West London. So we will be doing a number of tests, both at a South West London level and at a national level, to make sure that we can deal with any industrial action that takes place. At the last board, we talked about the delegation of specialised commissioning. And as you know, in South West London, working with South East London, we were keen actually to go forward with delegation. There was a national decision made by NHS England that actually, I think we were the only people nationally that wanted to move ahead with the specialised delegation, and that therefore that we would pause the formal delegation for a year till April 24. However, the national team are very keen that South London do some pilot work on what it might look like for April 24. So we are meeting with London Region and the national team over the next couple of weeks to understand what that might look like without having the fully formal delegation, how we might still kind of shadow some of the work that we were doing, and we'll bring you an update on that as we move forward. And delegation of pharmacy, optometry and dentistry, as you know, we brought that as well to a discussion with the board, and we have done an assessment across London because we did believe that for the formal contracting team, that when the delegation happens, we ought to keep them together in one place. And we have agreed across London that North East London will take that team on our behalf, but that we will have, we'll ensure that we are able to influence that and that we work on the local issues locally, but that the contracting central team, because they're only a small team, will actually be retained in North East London. And that was the end of my update, but I'm happy to take any questions on those.
Any questions from members of the board? No questions, Sarah. Ian.
No, Chair, there aren't any questions, but I do apologise. I do have a correction on the minutes with regards to my designation. So I'm down as the Chief Executive of Richmond as well as Kingston. So I don't want to cause my leader a shock. It's Kingston only. If that amendment can be made, and apologise for late notification.
Thank you, and apologies from us as well that we didn't get that correct. So if we could ensure that that's amended on the minutes that we discussed and approved, subject to that amendment. I'm just going to ask for confirmation that the board is content to note the report from the Chief Executive. Thank you. Moving on to item 5, ICB constitutional amendments. I'm going to ask Ben to speak to this item, please.
Thank you, Chair. As members of the board may recall, the first draft of the Integrated Care Board's constitution was based on the model constitution and accompanying guidance that had been produced by NHS England as part of the establishment process for all ICBs. As with all ICBs, the first version of the Constitution was approved by NHS England as part of this establishment process, and we brought that version of the Constitution to our first meeting back in June. NHS England have now asked, again, all ICBs to make minor technical amendments to their constitutions, as is set out in the paper. Sarah, as the CEO of the ICB, has reviewed these changes and is happy to recommend that the ICB should adopt these. And if the board is content to adopt these changes, we will then send this version of the constitution to NHS England for final approval. That's probably all I needed to say, Ruth, given they are very technical and fairly minor in in content.
Thank you, Ben. I will just check that there aren't any questions from members of the board for Ben on the amendments. Okay, so Mercy.
I don't need to remind the board, but just for members of the public, under the 2002 Healthcare Professions Act, social workers are included. So just to make it clear, often we use the term healthcare professionals and only think of the kind of NHS, but actually it covers social workers as well.
And do you think there needs to be an amendment, Mercy, as a result of that?
it completely, the Act completely covers it, and because we reference the Act, it's fine.
Thank you. Any other questions or comments? Okay, thank you. Is the board content to note the amendments to the Constitution in line with NHS guidance for final submission to NHSE?
I think, is it, sorry, Chair.
Sarah.
Is it a decision actually rather than a note? Can I just check that?
So it's content to adopt those provisions that we made and then to NHS England for final approval.
Very good, Sarah. You're right. It's we're asked to agree the updated Constitution so that it can be sent to NHSE for their approval. Content to do that? Yes. Thank you. Okay, item 6, vaccination programme. So could I ask Una Dalton to take a seat at the table, please?
Great, thank you.
The floor is yours on the vaccination programme.
Fab, thank you. Thanks everybody. I just thought I'd do an update to the paper that you've got in your packs, in particular the progress that's been made since the paper was written. So we're making good progress here in South West London with the booster programme. We're well underway and we anticipate that we'll finish somewhere towards the end of December. Certainly come January we don't expect people to be coming forward for vaccination. South West London is doing very well. We're the highest in terms of uptake across all London ICSs, but we do recognise that London is slightly behind the rest of the country in terms of its uptake. The programme has become quite complex in terms of the numbers of areas that we have to cover. It includes COVID, flu, polio, monkeypox, MMR, general childhood IMS, and this week we've had the addition of diphtheria for our SINs. Overall, we are seeing less people come forward, certainly a lot less than we anticipated, and there's a huge amount of work being done across all boroughs with our comms and engagement colleagues in terms of how we make our vaccination offer as easy as possible, and we encourage people to come forward to be vaccinated. But I'll hand over to Charlotte in a second, who's going to just give a bit more of an update on that. In terms of numbers, COVID, we're now up to 45% of the eligible population, polio 28%, flu 31%, monkeypox we're still at just over 63%. So for some, we're slow by comparison to last year, but overall we're doing relatively well. There is a huge focus on our roving team over the coming weeks, in particular taking vaccination out into the communities. And we've got 3 priorities there that I thought I should share. One, the first priority for the next 3 weeks is underserved communities, homeless, refugees and asylum seekers and travelling communities. The second priority will be on unvaccinated children. So we know that we've got about 20,000 children that have had no polio vaccination at all. When we look at where those children are across South West London, Croydon has about 6 out of the 10 wards. So we're going to focus on Croydon and one ward in Wandsworth. So that will be the back end of November, early December. And from there then, for the rest of the year, we'll just focus on low uptake areas across all of South West London, and in particular the areas that our borough leads would like us to go into. The key issues are still the same as in the paper. Demand is just not as we expected. Low uptake across the health and social care workforce. In particular, I would stress that care home staff uptake is very low at about 10%. So we have a bit of a campaign planned for late November, early December with some of our care home managers to try and encourage them to encourage their teams to be vaccinated. We're also decommissioning our 3 shopping centre sites at the end of December and going through the process process of making sure that happens properly. We've got a bank of just over 1,000 staff that we hope we will be able to keep in the system, but I think it's important that we bring this part of the programme to an end properly. Diphtheria has been added to our list this week with an outbreak down in Manston in Kent, where a number of people have come into the system across London and across the whole country who need to be vaccinated. So our job over the course of the next few weeks is to work with our Director of Public Health colleagues across the system to try and identify these people and ensure that we make an offer of vaccination, and they also have to have a round of antibiotics as well. And the final thing I was going to say is we are in the process of writing a new immunisation strategy for South West London, which we hope to launch at some point in the new year.
Thank you. Charlotte.
I suppose just to give the board an update on how we communicate and engage, because obviously that's an important part of getting people to get their vaccine. So we do use an insight-led approach, which means we talk to people and we adapt how we communicate and engage. And I suppose over the last 2 years, we have talked to thousands of people, but in those last 2 years, there are two really common themes of feedback that consistently come back to our engagement leads. And the first one is trust. So trust in the vaccine and trust in public authorities. And the second one is really about giving people facts. So we don't persuade people. So we started out 2 years ago persuading people to have the vaccine. That does not work, particularly with certain sections of our community. So now our approach is much more about giving people the facts so that people can make informed choices. So we have really adapted the way that we go out and talk to people. And I suppose really what we try and do is get clinicians, local clinicians, to have relaxed conversations. So we had a big campaign around come and have a chat. It's less about a formal consultation. It's a non-judgmental conversation. So that's been really important. And that's why we've worked with our voluntary sector and the local authorities so closely, who have really deep reach into communities, so we can really connect with communities. And I suppose at the moment, so, you know, Una's talking about our numbers, the two themes, again, that we're getting back from communities at the moment is, the first one is, I've had 2 vaccinations, surely that's enough. And the second one is, you know, I've had COVID-19 anyway, and I had the vaccine. So all of our communications now is focused around, actually, the booster offers you protection against the new variants, and vaccine protection does decrease over time. So because we work in the area, we think everyone knows this, but when you go out and you talk to people, people don't. So we're doing a lot of innovative things. We've got kind of information on pharmacy bags. We're doing a lot of kind of videos and actually voice notes on WhatsApp, because they're very easily shared among different communities. And the highlight will be our street ambassadors. So working with the voluntary sector to get people out on our high streets with lovely big tabards, having those informal conversations with people and signposting where people can get information. And I think just finally, it's about joining it all up. So we're moving more to talking about winter messages rather than just vaccine. And that's the same for all of the different kind of immunisation programmes.
Thank you. Clearly a really important area of work, so thank you for both those very clear updates and the work that you've been doing on this. So questions from the board. Ruth.
Thank you, and thank you for all the work that you're doing. I absolutely recognise that the communications is happening in an integrated way, and I'm really grateful to Charlotte and the team for making that happen. But if this is going to be successful, it isn't just about communications, it's about engagement. And what I'm not seeing in the report is how we're actually engaging with the local authorities, with their insight into their local communities, their understanding of where we need to go in order to have those conversations, rather than waiting for people to come to us. So it's great we're going to have people in the high street. We've learnt a lot from the COVID vaccine. We've learnt that actually just waiting for people to come to us, particularly those people who are more hesitant, that just isn't going to work. As local authorities and working with the voluntary and community sector, we know where to go. We also know the times to go. And I can think of, sadly, of all sorts of examples during the pandemic where there were very worthy initiatives to do pop-ups, but in the wrong place at the wrong time. So what's worrying me is that there isn't that level of integration with our knowledge and our insight in order to make this successful. And just as an example, the report says during November we'll be holding a focused 1-week vaccination programme for each borough. My borough doesn't know when that week is. We need to prepare for it. There's an awful lot of added value we can give to that, but we've no idea when it's happening. And if we get told the day beforehand, it's just not going to work.
Yeah.
Hi. Yeah, so absolutely. First of all, a big thank you. I think we've learned a lot and we've moved on a lot. And in a way, with all fairness to both comments, I think Una has been a God's gift for coordinating across the boroughs as well. So there's an immunisation steering group now that we, at least as public health people, try to feed in. A lot more to be done, but credit where credit is due, we never had that. So really, really keen to continue and grow that. And I was particularly thinking our closeness to staff, our own staff and care home staff, because that worries me most. Because if staff isn't convinced, the clients and residents they're interacting with will also not probably be as getting as convincing information. So absolutely, Una, come to us, knock at our door, demand that we support, and we will pull out all our stops, because it is about winter resilience.
Una.
Great, thank you. I suppose just to reassure you a bit, we meet with local authorities every single 2 weeks and have done now for the past 18 months, and that's a two-way conversation about sharing where we can complement each other in terms of the work. So we're absolutely committed to that, and I think we've had really positive feedback from all the local authorities in terms of that ongoing conversation and working out where best we can use your contacts to get into other places to offer vaccination. I use Croydon as a good example, and the children's centres where we've managed to locate a number of vaccination clinics later on this month, purely through using our local authority contacts well. We also have representatives at the borough engagement meetings as well, and I think the 1 week conversations that we're having with each borough, we have been talking about them now for about 3 months. So I'd be disappointed if a single local authority were not really up to speed with all of the efforts that are going on. But we can continue to build on them, of course.
Just really quickly then, do we know when that week is?
So I don't know what borough you're in, sorry.
Sutton.
Sutton is this week. So yesterday, we vaccinated, I think, 40 people. We were in 3 different organisations with the local voluntary sectors. We went to a learning disabilities, a carers organisation and one other. So I think Sutton colleagues are well and truly involved in this programme. So I don't know who in the local authority we would need to engage with, but happy to take it away.
Yeah, could you perhaps take that away
Yeah,
and then
sure.
Go back to Ruth?
Yeah.
Okay.
Yeah, Sarah.
It might be helpful if we actually just drop Ruth a line and say who's been involved at your end and make sure we've got the right people, because I think we just need to make sure that the communications are in the right place. And then, Ruth, if you've got other people you want to be involved, we can make sure we involve them in.
Yeah.
And if I could have the weeks of the other boroughs as well, that'd be really helpful, because then I can make sure that my equivalents know in each of the boroughs.
Of course. Yeah, will do. Yeah, thanks.
Mercy.
Yeah, a few questions from me, Una. I'm right here. Obviously, I sit on the board of the vaccine regulator, so I'm very interested in this area and quite concerned about the low uptake, especially amongst staff and care home staff in particular, but also trust staff. Obviously, we produce information all the time, especially international feedback on reaction to vaccines, and we're also the WHO Polio Centre for the Eradication of Polio. So obviously we've got a, kind of a finger on the pulse, but it is concerning when we get out to the public that it's really good to hear Charlotte's kind of really directed sort of insight into where people are coming from. But getting those facts out there is kind of an issue, I think. And I wondered if you also thought about the general low profile of COVID-19 at the moment in, the press and things. It's not an issue, but obviously for us in our hospitals and things it is. And just informally from execs at the MHRA, we wonder if that is part of the reason there's lower uptake. And I also wanted to know about the success of the roving teams as well so far.
Sure. I suppose one of the things about the messaging being out there is the national comms campaign. I think it only started last week, so it was very slow on the uptake. So I hope we've not missed a trick by that slowness. But I do think locally we're doing all we can to try and get that messaging out, for sure. In terms of the roving team and its success, It's so variable. I mean, it's the more expensive arm of the vaccination programme because we have to fully staff it, we have to bring out vaccine, but we might only get 1 or 2 people. But I think it's the most important arm of the vaccination programme that we do it. I don't have a formal set of numbers I can give you, but we certainly are doing a review of the team and its impact. So that is something we could share with you separately, if that was okay. Yeah, great. Thanks.
Sarah?
I wonder if we could, at the board level, get even if we don't bring papers back every time, but we get a regular update on numbers, both from population but also staff. I saw the flu uptake for our providers the other day. It's moving up, but it's still quite slow. And I think also people are just vaccine, they're vaccinated out, aren't they, a little bit. So even for flu, which we usually do very well in South West London, and can I just say we are still the best in London, I will say that, but it's still not as high as it needs to be. And so I think it would be really good that maybe we just get throughout the winter, throughout this time, maybe just to the board a regular update of the figures across South West London, so we know both for all the different vaccines, the percentage that we've got, and within staff. That would be really helpful, I think.
Thank you. Any further questions? Matthew?
Just 2 points, Chair, if I can. The first is, I concur with Sarah. I think there's a bit of what I would describe as vaccine fatigue out there. I talk about it with my staff all the time, just within the Croydon context. We have a webinar every week and we're talking to people about it. We've got a vaccine hub on site and we're putting roving staff out to the community sites that we look after, but it's hard yards to get that uptake, and I don't think that's because there's massive disillusionment with the vaccine. I think people are just, they've gone past that point in their minds, and so it's beholden on us to keep pushing, encouraging, educating and making it available, and that's what we're doing. I check the figures every week that Sarah has seen, both on flu and COVID, and you're right, we are steadily increasing, but it's slow progress, and we just have to keep it going, but I don't expect it to go massive uptick unless the national campaign, a mutation or something else happens to then bring it back up the agenda. I think that's just being realistic. The second thing I wanted to say is, sparing Una's blushes, we have an annual awards at Croydon, and the vaccine team are actually employed through Croydon as the employer. So the vaccine team for South West London won an award last week at our annual STARS event for partnership working, and I thought it would be right for the minutes to note that and to congratulate Una and the team for their hard work. So.
Thank you, Matthew. So if we could note that for the minutes, and also the additional information that Una will provide to Ruth and Mercy, and finally the regular updates that you'll provide to the board going forward on uptake. Thank you. So is the board now happy to note the contents of the report? Thank you. Thank you, Una. Item 7, winter update. So could I ask Jonathan Bates to speak to this item, please? Thanks, Jonathan.
Thanks very much, Chair. This is a verbal update because it's obviously a fast-moving environment around the challenges we face this winter. But happy to circulate the narrative I'm sharing afterwards if colleagues would find that helpful. So there's 4 areas I was going to cover. One is an update on the winter challenges faced across the system. Then some of the successes and progress we've made to date, progress on the investment decisions we made back at our September board meeting around winter monies, and then finally additional actions that we've been taking over the last month since you received an update a month ago. So beginning with the winter challenges, whilst I'm sure it doesn't feel like it out there in many services, actually the demand for urgent emergency services is largely flat. Year on year, the number of emergency department conveyances by ambulances is down by about 10%, for example, to illustrate that point. The pressures on ambulance services remain very significant, as you can see in the performance report presented here in the papers, and the London Ambulance Service and indeed South East Coast Ambulance Service, which support some of the trusts in our system, have both instituted their rapid release protocols to help get ambulances back on the road, handing patients over to the emergency department as rapidly as they possibly can. It's fair to say discharges remain stubbornly low in comparison with where we would like them to be at this point in time, and there is an immense amount of work taking place to try and address the challenges there. An example of that would be the work that St George's is currently doing to institute the Bristol model, where patients are moved onto wards in anticipation of discharges that are going to happen regularly through that day. I think it would be true to say for our trust colleagues, whilst the overall demand might be down somewhat, the daily and weekly variation in that and some of the pressures that represents, particularly at weekends, and given the bed occupancy levels that we're operating at, present very distinct challenges. And I think the 12-hour breach position, so the number of patients who spend 12 hours in the emergency department from arriving, it will be probably the highest we've seen actually in October when we report those numbers. I'm pleased to say for mental health it is a stable position, but for physical health it continues to rise. The number of patients who spent more than 21 days in hospital is about 1 in 5 of our patients across our trusts. So that remains a key issue for us. And whilst there's an immense amount of work around community response, there's more to do to drive forward things like the virtual ward agenda, where currently probably about half the beds are occupied. And it's a new service model, so it takes time to change practice, but nonetheless there's more to do in that space. So that would be my first element of the update about the challenges. In terms of the success, is both the Croydon and Sutton systems have already delivered more than they intended to at this point in additional general and acute beds, so that's good and that's on track. Thank you to colleagues around the table for supporting the additional beds that we have sought in nursing homes and for people who have COVID and who are leaving hospital, and the re-establishment of the Bed Bureau. Hopefully we can maximise the use of that across all 6 boroughs, but that went live on the 1st of November. Additional neuro-rehabilitation beds are in the system, both at the hyperacute end at St George's, but also in less acute settings, and that will more than double the number of neuro-rehabilitation beds that we have in the system over the coming months. We're working with London Ambulance Service on an urgent community response car that was presented back at our Urgent Emergency Care Board last Friday, and I was certainly very interested in the number of Category 2 calls being managed through that service. So those are ill patients, stroke type patients in Category 2. The board also received, the Urgent Emergency Care Board on Friday also received an update on homeless people's project and the work we're doing particularly in Croydon and St George's systems to provide routine care and support people around stable housing and rehabilitation services. Also good to report that our 111 service that went live in the summer is now delivering a stable service for our population. Around 10% of patients are going onwards to emergency departments or urgent treatment centres, and about 40% back into the community, and the service is now handling around 40,000 calls a month, to give some idea of scale there. And also, I think good to report that COVID numbers in hospital are falling, so that's good to hear. The third element around progress with winter schemes. So as I said earlier, we put 40 physical additional beds into the system by the end of October, which is actually ahead of the plan that we previously signed off to achieve a total of 157 beds by mid-winter in January. It would also be true to say, though, that some of the admission avoidance schemes that we plan to put in place, we need to pick up the pace of those, and we'll be working with colleagues across the system over the coming weeks to do that. And then in terms of additional actions for this winter, we received a letter from the NHS England Chief Executive, from Amanda Pritchard, in October, and that sought for us to take a number of additional actions. Some of them were about supporting people in the community. So, for example, ensuring our community full services who were as resilient as they could be, maximising virtual beds, as I've said already, reducing conveyances and the variance in conveyances from care homes via ambulance to hospital. Increasing our bed occupancy and bed capacity in the system, and also establishing system control centres so there is a good understanding across the system of the pressures and how to manage those collectively. Increased emphasis on timely discharge, something we've already touched on, the 100-day challenge particularly, and the 500 million to support social care. That letter also touched on a number of other areas, including the self-vaccination point that we've already talked about at this board today, things like infection prevention control, elective recovery, etc. And finally, it mentioned a 10-week national improvement collaborative. Colleagues from all 4 trusts are in that meeting at this very moment in time, and that's a national programme kicked off a couple of weeks ago to seek peer review and learning from colleagues across the system around things like risk-based flow and streaming and redirection of patients. One other thing to flag, Kevin Fenton, the Regional Public Health Director, shared in October a winter framework for London, and that's slightly broader than the immediate pressures we face. So I'd encourage place colleagues and A&E delivery boards to look at that. That looked at things like long-term conditions management in primary care, the importance of high vaccination rates, as we've already talked about, and communications that we've also touched on as well. So that would be a sort of brief summary of the immense amount of work, frankly, difficult to do justice to the immense amount of work of system partners that's taking place at this point in time, and that's a summary of how we've progressed, Chair, in the course of the last 4 weeks.
Thank you, Jonathan. Huge amount of work that you've outlined there. Could I ask for any comments or questions from the board, please? Matthew.
Thank you, Chair. Just on the back of what Jonathan, I'll endorse what Jonathan said, but I thought perhaps as joint SRO it might be worth me adding a couple of additional points. I mean, I think the first, and I'm not one to shroud wave, that's not in my nature, but I think the scale of risk and challenge that exists in this pathway, you know, needs to be acknowledged, understood by all members of the ICB, as I know it is, but I think it's important to note that if you look at any part of the system, it's all under significant stress and stretch, and we should sort of ignore that fact, as we are not, but worth noting. I think that's true for both patients and families, but also for staff. And again, that is not just the proviso of emergency departments by any means, it's all parts of the urgent emergency care system. And I think, you know, the impact for staff after 2 years of a pandemic and then straight into this should not be underestimated, and it's certainly something that I know everybody feels keenly and is doing a lot of work on, but again, important to note. And just because I'm the warm-up act really for Vanessa, I think it's important to say that is for physical health and for mental health. There is a real issue here of not just thinking about people in the back of ambulances who are with physical health challenges. This is you know, some of the bigger concerns that I have is down the mental health line, and mental health of course is not just the patients we see in ED, it's mental health patients who we may not be seeing at all through that part of the pathway but are in significant distress. So I'm sure Vanessa will be more eloquent about that part than me. What I would say though is on the back of that, we're not sort of sitting still and going, oh well, okay, well it's really, really difficult and you know, let's just try and do everything we can to support people, but just say, well that's how it is. There's a whole load of additional work. So Jonathan's right, we've got a lot of schemes in play, but certainly in my patch, and we talked about it at South West London Urgent Emergency Care Board on Friday last week, as Jonathan said, there's other ideas and other initiatives coming forward from each area, which is good because we need to respond to the current reality, not the reality that it was when we started doing the planning earlier in the year. So we in Croydon, just as an example, are looking at more initiatives with social care, for example, around Pathway 3 capacity, as a way of trying to just take the edge off some of those delays that are in the system. That is by no means the only aspect of it. There's quite a lot of in-hospital work as well, but there is a section here which is about what we do collectively as a health and care system. And so additional work that we're doing around Pathway 3 beds, we hope will help to take off some of those exceptional pressures that we're seeing on many days at this moment. And then I would just reference, and it may well come up later, of course, but virtual ward, we go live on the next phase of that later this month with the monitoring hub, which we are looking forward to and hoping that that gives an additional push to the benefits that we could take through the virtual ward, with Sutton and Croydon going first. You'll be pleased to know, Ruth, building on the success that Sutton's had already in that area and the experience that Croydon's had, and that will then roll out across the rest of South West London. So that hopefully is another example of, we're not just doing the same things we've always done and hoping it's going to get better. We're looking at different things and how we can, innovate to try to address and respond to, it has to be said, perhaps for a prolonged period, the biggest challenge down the urgent emergency care line that I've seen in 30 years of working in the NHS, and I don't think that's overstating it by any means.
Thank you, Matthew. Sarah.
So there were two issues. One is I think we do need to make sure that we are using all of the resources that we have. So the virtual wards, I think unless we use those and we actually get the benefit out of them, I think that the money for that we will lose if we're not careful. So I do think, we need to make sure that it's not just about making sure that we develop a good model. We must make sure that we use that, because I think we'll lose it otherwise. That was the first thing I was going to say. And I don't know if you were going to talk about, all right, so I will let Karen talk about the Innovations Fund, because I think this is something that we talked about as a system, and it's something very different, but again, it's focused on the winter time, so I'll let Karen talk about that.
So Karen and then Mark.
So I was just going to say, in addition, one of the initiatives from the Integrated Care Partnership was to release £4.9 million worth of funding for schemes, innovation schemes that would support winter and make winter across South West London more resilient. And we had something like 170 applications, totaling about 28 million in terms of the initial interest that came through, and we are working through those at the moment. But there's a huge amount of innovation, a huge amount of great ideas out there that we will release funding into the system this winter, so that we can use some of those things to make a difference and then see whether actually we scale them. But some great things, I think, happening that we can report in future meetings.
Thank you, Karen. Mark.
Apologies. I suppose I'm just bringing primary care into the conversation, really, and just to say that there was a change in our kind of extended access with primary care at the beginning of October, where the contract went to PCNs. And in South West London, we've increased appointments from 6,500 up to 7,200 in primary care. So increasing the access is really important. I do also just think there's a comment around particularly the winter monies. That one of the struggles, I think, is about workforce. And actually many of the initiatives we're talking about require additional workforce, or if they don't, we need to think of it in a different way, really. We need to think about innovations and not just more bums on seats, because we're all fishing in the same pool, and actually across the board there's many pools that are quite dry at the moment.
Thank you, and I think it's a really important point on workforce, because I think everybody is fishing in the same pool, and so it is important to think of alternative ways. So I'm going to come to Vanessa, then Ian, then Dagmar.
Thank you. So it's always a pleasure when one of your acute provider chief execs talks about mental health in the round rather than just in ED, so thank you for that. I would say that the demand pressures remain very significant, and for us actually the number of patients that are going out of area or into the private sector, I think is a really real concern for us. But the point I wanted to make was around resilience, and I think the innovation funds have been fantastic, and whilst they do draw on the same pool, they draw on a different pool from us healthcare workers, for want of a better way, and I think there's something really commendable with that, and we can do some solid work with the third and voluntary sector, but I think that requires us as an integrated care board to think very differently about how we plan, and that these short-term pockets of money present a real risk to our third and voluntary sector because they can't long-term plan and they move from one bid to another. So I guess there's a question or challenge to us as a board as to how can we help make this more sustainable, so that actually we change next winter as well as this one.
Thank you. Well, we'll come back to that in a second. Ian and then Dagmar.
Yeah, thank you. Mine's about the innovation funds as well, and I welcome this too. Are we giving thought to the evaluation of the impact of the funding, and this is work, I apologise, but feedback for the unsuccessful bidders would be something that they would value, I think.
Thank you. Dagmar, is your question about the innovation fund?
No.
Okay.
No.
I'll just bring Karen in then to respond to those questions about the innovation fund, and then Dagmar, I'll give you the final word.
So I talk about this year first and then future years. So yes, Ian, we're going to do evaluation. So we did ask about the impact in the bid document themselves. They were variable, I think, would be the best way of describing those. So we've done some further conversations around what would that impact be. I think we're probably going to be needing to work with a lot of organisations throughout the implementation as well. But it's a critical point, isn't it? Particularly if we're then going to scale those things. In terms of the evaluation, so we released the money very quickly, we recognised that, but we wanted to make sure that we got as much money into the system as we possibly could to support winter. We are going to do an evaluation of the process from the bidder's perspective. We're also going to feed back where people were successful and where they weren't. We had criteria, so that's easy to do. But we also want to hear what it's like to bid and what would be helpful if you're bidding in future years, because we want to make it as easy as we possibly can. We'll also take evaluations from the panel that will make the final decisions, the shortlisting process that we've gone through, to make sure that we develop a more rounded process as we go forward. So that will be an issue. We do want to release further innovation funding, just in terms of Vanessa's question. I'm not sure I've got an easy answer for Vanessa's question, but we will look at making sure that the innovation pot in the future looks to develop the integrated care partnership priorities and is targeted on those things, to make sure that we look at longer term as well.
Thanks, Dagmar.
Yeah, so again, speaking from a place perspective, I wanted to raise the issue around the cost of living crisis and the sort of immense work that local authorities are actually doing, and that we can still work more hand in glove of that. Because if we're really looking, quite a number of our low-paid staff fall into that category, and have we got that right? There's quite a stigma and shame involved to admit. So I feel jointly we can make that work even better, so that everybody who can benefit from quite a lot of activity that is offered in local authorities actually come forward and do it. And I think you, as health partners, could help us as well a bit to channel the health staff into the office.
Thank you. Yeah, Sarah.
Just because, I know the providers are working across South West London on what the offer is to those staff and making that available to them. So we need to make sure that we're channeling in local authorities, and I know, Karen, I wonder if you take that away to the HRDs, because there's work ongoing already around how do we align that across South West London. There's also a national NHS offer for low-paid staff as well. So we just need to make sure we're joined up on all of those things, Dagmar.
Thank you. Jonathan, final word.
Thank you very much, Chair. Just wanted to make the point about the need to be fleet of foot on all of this. We're already in mid-November. We need these schemes to be impacting. It will be quite difficult to Mark's point, to recruit people in December into some of these roles as we sort of enter the festive period. So we've already been fleet of foot. We've already refocus things to secure additional care home capacity. as I said earlier in my report, but just as using this forum as an opportunity to say to everyone we need to keep the foot firmly to the floor to deliver the innovations, the service changes, the improvements that we set ourselves. And if we find that something isn't going to quite deliver in the way we expect it to, then please would colleagues flag that to Matthew and myself so that we can make sure we invest that £13 million for the best interests of the people of South West London. Thank you.
Thank you. There's been a lot of discussion on this topic, so I think it's really important that we continue to bring back these updates for each of these meetings, because as Matthew says, and as you've said as well, Jonathan, this is a key risk area for us, and it's absolutely critical that it includes partnership, cross-sector working in order to resolve it. And I think drawing on the innovation as well, what long-term changes can we make to address some of these issues, because undoubtedly we'll face further pressures throughout the year, but also at the same time next year. So good to learn from those and see what we can do in advance. Thank you. Moving on to item 8, emergency preparedness, resilience and response, core standards self-assessment, and it's over to you again, Ben.
Thank you, Chair. So each year we're asked to carry out a self-assessment process of our ability to respond in the event of a major incident. The assessment is carried out against the Emergency Preparedness, Resilience and Response EPRR core standards framework. During COVID, CCGs were required to assess themselves against a slimmed down version of this assessment. And this is also the first time that we've been asked to assess ourselves against the full set of standards for a Category 1 responder, CCGs previously being a Category 2 responder. The essential differences and responsibilities that are listed in the paper are there for Category 1 responders, and Category 2 responders are there really to support Category 1 responders. So, as the board will see, we've marked ourselves as being largely compliant with all of the standards. The only one where we believe we're amber against is the provision of a 24-hour logist support service. While we do have a group of trained logists within the organisation, they're not available out of hours. And while we'll continue to keep this under review, we believe there's a small risk attached to this, and that's a proportionate response to our responsibilities at this point in time. So the next step after this is that we submit our self-assessment to NHS England. We will meet with them in December to review that before their final sign-off and agreement to that core set of standards, and we should get that towards the end of December, hopefully, and I'll return to the board with any feedback from NHS England in the new year. It's probably worth noting as well, Jonathan just touched on this, we have had some more guidance from NHS England recently about the establishment of system control centres, and we're currently working through the requirements and the guidance on this just to make sure that we meet all of those requirements, and there might be a few changes to the structure of the team that we need to make to ensure that we're fully compliant with that. That's probably all I needed to say, Ruth. Very happy to take questions.
Thank you. So the board is asked to review and discuss the core standards position and the self-assessment of the ICB. Are there any questions or comments that people would like to feed into the assessment? Charlotte?
Yeah, so I'm just looking at it. So obviously Category 1 is a shift, isn't it, in changing what we do, so in our kind of organisation for our staff, and people around this table will understand and know that we're now a Category 1 responder. But I was just thinking about the other partners, the wider partners we have, so like the emergency services, you know, fire, police, because they will have to interact with us in a different way as we're Category 1. So I wondered, are we talking to people locally or is it happening nationally? Sort of your view on that, really.
So I think the answer to that is both, actually, Charlotte. So it's happening nationally at a London level. We have a London Health Resilience Partnership that brings together all of those players. Locally, we have Borough Resilience Forum, as many colleagues around the table will know, and that brings together all of those responders, of which we go to regularly. We've had conversations at most of those about this, I think not all, and we've also had conversations with all of our trust partners about the difference between sort of being a CCG and an ICB as well. So it's a work in progress, but only came in July, so we continue to have those conversations as we go forward as well.
Karen.
Ben, I just wonder whether it's worth assuring the board that we're also going to test these arrangements, aren't we? Do you want to say a little bit more about that?
We certainly are. So as part of, and actually as part of meeting the assurance standards, we need to carry out regular training and testing against our abilities to respond to that, as again individual trusts around the table will do. We started our training programme for that this month with all of our on-call directors, so the people who would be called in the event of such an incident, and without giving away too much to anyone around the table or our staff will be participating in this. We will be running a training, so a scenario-based training exercise on that over the coming months, shall I say.
Thank you. Dagmar and then Sarah.
So thank you very much and welcome. I just wanted to pick up Charlotte's points. So local authorities obviously also category 1 providers or responders rather. So really important, and in terms of scenario planning, I was sort of reflecting strikes amongst our essential staff over the winter fills me with dread, to be honest, particularly across local authority services and health. You know, if that chain breaks, we're in a real pickle. So that would be something quite concrete to practice both our category 1 response. Thank you.
Thank you, Dagmar. Sarah, and then I'll bring Karen back in.
So I'll answer a little bit of that before I move on to what I was going to say, which is that is already planned. There's a national planning that we are going to be taking part in around the strike. So that's one of the incidents that we will be practicing as we go forward. I won't tell you when, but we will be doing that. What I was going to say is just worth the board noting. We learnt a lot during COVID, and actually, even though we were level 2 responders during the COVID campaign, we, in many ways, we behaved as level 1 responders in setting our incident control room up and doing the work that we were doing because we were asked to by NHS England. So we did that. We are now taking that one step forward. So, you know, our incident control room is being reviewed, as we say, but I just thought it's worth noting that Karen is our emergency care accountable officer. I can never remember what it's called.
Emergency responsible parents.
Yeah, she's the emergency accountable officer, and I have a role as accountable officer, and Ben is doing the work reporting to Karen on that. But it's just worth people knowing that's where the formal accountability for the board sits, just so everyone is aware of that.
And a quick question from me, if I may. I had very similar questions about the kind of testing of this, and particularly around the potential for strikes in the future. But in terms of that testing, will it look at the pressures that might arise across the system, not just within providers?
So not to give too much away, but it will test multiple things arising maybe at the same time. But we are just in the design phase of that with the national team at the moment. Can I also just pick up the strike part as well, though, because one of the so the NHS is obviously now responding to the Royal College of Nurses ballot, and there is a lot of planning that's going on in both organisations and throughout the different tiers in the NHS. We have set up a South West London team to look at that, and we will join with the trusts every week to look at preparedness for strike, and we will link with both the London incident management teams and also the national to make sure that we have as good a response as we possibly can do to that impact. And we obviously also have further ballots going ahead with other trade unions, so that will potentially be a moving feast, but we do have a planning mechanism for that at the moment within South West London.
Thank you, Kelly.
Thanks. Can I just raise the issue of the logists? And the reason I'm doing that is that I get why you are where you are at the moment, but having been through a catastrophic fire at the Royal Marsden, one of the learnings from that was having availability of logging decision-making at each moment very accurately, particularly if, you know, there's a fatality or something awful happens as a result. So the learning from all the emergency services, and I'm conscious I'm here with a specialist hat on for ambulances and other things as well, is having that logging capability right from the get-go of a major incident. So I just put that out and perhaps keep that under review, or maybe have a fallback plan, because individually as providers we have to have a logging system. You know, I'm a bit worried that we can't do that 24/7 if we absolutely had to for a major incident of some kind.
Thank you.
So just say,
Yes, Sarah.
well, I mean, I think that's probably right, and we've got that we would keep it under review, but maybe we need to go back and have a look at that. I think we've already had that feedback, haven't we? So, yeah, thank you.
Thank you. So is the board content to note the position in self-assessment and its submission to NHS England? Thank you. Item 9 on the agenda, People and Communities Engagement Assurance Group update. And Mercy, I believe I'm coming to you for the update.
I think Charlotte's going to start and then I'm going to finish, as they say, so.
Thank you, Doc. Yeah, so I suppose, I mean, obviously the report is there. I suppose we just wanted to emphasise 3 things. So I suppose the first thing to say is we want to evolve this group as our system matures to make sure that it adds value and make sure that we are sharing best practice engagement with our patients and communities. The other thing we were keen and we spent quite a lot of time talking about was really getting the group's advice for how we create that culture of engagement. So really enthusing our staff across the system around engaging our kind of patients and communities, and you know, if we co-design services together, the services will be better, and how we need to do that. And I suppose it's a mixture of, so in the report we talk about the legal duty, but it's kind of carrot and stick really. You know, we need to say to people it's worth doing, it will help you, services will be more efficient, more productive, as well as, yes, we have a legal duty to involve communities. And I think the final thing to say really for me is around the potential that this group has because of Mercy being the chair of both the Quality and the Engagement Assurance Committee. So it'll really bring together, I think, patient experience and community engagement, because after all, our patients are still members of the community, but traditionally we've been quite separate. And I personally have found it quite hard to bring together patient experience with community engagement. So I think we have a real opportunity to bring it together, you know, with our voluntary sector, with our local authorities, our Health Watch. So we have, you know, a common forum to talk about what local people are thinking and feeling about our services. And we're very grateful and lucky that Mercy is chairing both of those groups, because I think that will really help.
So I was just going to comment about the fact that it was really good to get this group underway. So to actually set it up, we've still got a few people that need to be kind of put forward as members of the group, especially I think non-execs or people with lived experience. So still waiting for some nominees, but overall we had a really good attendance and really good engagement for the first committee, because obviously we're going through things like terms of reference and, you know, what our purpose was and things like that. We got really good kind of feedback, and I was really trying to get feedback from, you know, all members of the committee, and I think that's really important that everybody can really develop this for it to have meaning and impact, and that's always been my buzzword about impact as an assurance group. I see it also as a kind of a learning centre, so we got good examples of what's happening within various places and providers, and I think that's going to be a feature as we go forward too, so that we can kind of really learn across the system. I think those are the kind of the main main things to say. Hopefully, because it's a quarterly committee, we can give people enough notice of the next date of the committee so that we can have full attendance. And the idea is to review the terms of reference as we go along to make sure that it's fit for purpose.
Thank you. Could I ask for any questions or comments from the board? Otherwise, Liz, I thought I'd just give you the opportunity to come in here and ask any questions. Liz is the Health Watch representative.
I am indeed, although as from the 14th of December, we will have a paid executive officer undertaking the role. Well, because I'm thinking of a 9 o'clock meeting in January that I won't have to attend. Yes, it was a very useful meeting. I thought there was actually, it felt as if, and I haven't had the chance to have the discussion, Mercy, with you, as if there were two different agendas slightly running with different members. So, I'd be interested to have a chat whether that was your impression, and if indeed, how those two are brought together. One of which I think was about the more kind of proactive element of service design, and the other was, if you like, the more reactive feedback of immediate patient experience, and the two seem to be in play together. So it was perhaps looking at that. In relation to engagement, since I've been invited to speak, we are keeping an eye on the various activities that are being undertaken. And I gather that there's a South West London primary care strategy workshop at the end of November. And at the moment, there isn't any patient or public involvement in that particular meeting. So I did ask yesterday if some thought could be given to that. So I guess my point would be, could PPI be a golden thread throughout the, the activities of the ICB and its other bodies? So, excellent, the work that Mercy is leading on, but can we also make sure that it is that golden thread through other activities as well?
Great, thank you,
Thanks.
Liz. Nicola, can I ask you to come in response to Liz on that one,
well, thanks.
please?
So, yes, we're looking forward to our event on the 30th, when we're going to be talking about our primary care future. And my understanding is we have got involvement from patients. We've got representatives, and that is in place. So we'll go back and check and see who it is and make sure that you're made aware, Liz. Thank you. And if I may, I was going to raise my hand anyway, just sort of on the same theme, really. Just to say, I think it's really, really important that this meeting isn't a sort of an outpost of what we're doing. It's really important that we're discussing it here today. And if we're looking for, sort of industrialised kind of engagement really across, then it has to be really cultural, and it can't just be something we discuss in a meeting and report back here. It has to be something that we all really kind of embody and live, and that's really difficult when we're all talking about massive pressures in a system going into winter, but it's really, really critical that we all do, and as part of our organisational development as a board and in our system, I do think that's a really important element of what we all need to work on together.
Thank you. Charlotte, do you want to... Actually, shall I just bring Mark? Mark, do you want to come in? And then, Charlotte, I'll come to you.
Just in addition to Nicola's comments about the 30th, we definitely do have patient representatives, but also that's the launch event for the strategy, so there will be further engagement opportunities as we go through.
Thank you. Charlotte.
Yeah, music to my ears, Nicola, that you have talked about that culture of engagement, and I would like to come to the clinical leadership group and talk about how we get that enthusiasm and that kind of that culture and that movement going, really, because we have, I think, probably about 1.2 engagement people per place. We can't do that much engagement with 1.2 people, so it has to be everybody across the system engaging patients with support and facilitation from the engagement leads at place who will I kind of see like air traffic control, you know, introducing people and helping people get into communities along with the voluntary sector and local authorities, but definitely that will be a piece of work that I will be coming to talk to clinicians about, particularly as well as managers. But I think it would be good if clinicians could kind of front that up and lead it. So we'll be looking for some champions. Dr. Jones.
There you go. So, thank you. Is the board content to note the report? Thank you. Thank you. So we've got a quick comfort break for 10 minutes. I've kept us on track in terms of the agenda. So can we aim to come back in 10 minutes? So 15:49, please, so we can be ready to kick off at 15:40 exactly. And I will be ringing the bell if we don't have everyone back. Thank you. Welcome back, everybody. So we're moving now on to item 10 on the agenda, which is the ICB report. So at each ICB board meeting, we receive formal reports from the quality, performance and finance functions. The first report is from the quality team, and Dr. Gloria Rowland, our Chief Nursing Officer, will talk us through the report. Over to you, Gloria.
Thank you very much, Ruth. And I'm just going to take it that the report has been read, and I'm just going to highlight some 4 or 5 key areas. So the first thing is that workforce continues to be a big challenge across the system, and I think we've already referenced that during the meeting. More importantly, within nursing, we had sort of like a call from the national team saying that 2 of our providers actually are one of the top 10 that are actually not keeping their nurses. So the turnover rates are high. So we are working through that with those 2 trusts, 2 organizations, and they are doing well. They've got a robust action plan in terms of how they're going to resolve that. So we are working across nursing and HR to make sure that that is being resolved. So yes, turnover is a big issue across the system. Then the second area that I really also want to reinforce is around our child and adolescent mental health services camps, and I'm sure Vanessa will probably know more around that. We are continuing to face significant challenge in terms of that. And as Vanessa has alluded to, which also means that some of those, we are looking at external placements in terms of care provider, private care provider for those children. So I think it's about looking at sustainable plan for the future, as we have seen significant increase in terms of number of people accessing their services. And the next thing I want to talk about is few under safety elements is issue around never events, and I know we've spoken about this few times in the past. What we've done, as we've promised, is that we've done a deep dive into our never events. Although we are not doing badly across London, and I know nationally as well, as we've been told to check, we are not doing badly at all. However, what we found out is that when we did the deep dive, out of the action plan created by all the providers in terms of the never event, we found out that 97 of them, when we did what they call a barrier test on that, we did 2, are not strong enough. What that means is that we have tendency of having a repeat. So we are working with providers in terms of looking at that, how we strengthen those action plan, and I just want to report that. But that work will be going on with Quality and Oversight Committee. We will take that forward there. And I think finally, I just want to say something around CHC as well. With CHC, I know is one of the highest risk area in terms of backlogs. I just want to say here's a good news story. We've done very well in terms of clearing those backlogs. And we just want to make sure that we have a sustainable plan in place to make sure we maintain that. And also we've got other issues going on in CAC, but we've got external reviewer in to really help us with that. More importantly, looking at sustainable model of care across CHC. And I think that's all I want to mention today, unless we have questions from the audience.
Mercy, is there anything that you wanted to add as chair of the committee?
Well, I was going to ask a question, really. So, and this came up, it's in the report, but there's going to be a kind of new for us database, radar, which, and I just wanted to really know about, with any database or any kind of system, it kind of depends on the data that goes in and the quality of that data, and also the use of it for analysis and pulling reports. So this was new to me at the QOC, I have to say, so I don't expect an immediate answer from Gloria, but it'd be good at some point to have a little bit more detail on this new, because it's an investment as well. So that would be good to know a bit more about how it's going to kind of use any kind of analysis we can do to look into these things and to particularly pull reports.
Thank you. Let me see if there's any other questions. Gloria. Ruth.
Thanks. And it was really good to read this report because it helps me understand the pressures, the constraints, the huge pressure that we are all under. So it was, I really feel that being as part of this board, we're able to spread that information and that understanding wider. So it's great. My challenge would be, understandably, there is a focus on ED, quite rightly on CAMS and on CHC. But there's an awful lot of pressures in our wider system that are just as relevant. And I'm wondering if in the future we might want to work with some clever people to think about other metrics that will have an impact on the wider system, and by system I mean people's lives. So we know that there's a huge increase in demand on ADHD services and on autism services, and we know that there's a huge problem at the moment around speech and language therapists. I'm not suggesting those are necessarily the metrics, but I do think, Gloria, because we're an integrated care board, we can start to think about wider metrics and bring them all together in one place, and I think we'll all benefit if we do that.
Thank you, Ruth. Vanessa.
Gloria raised the issue of CAMS access, so I thought I should provide some clarity to make sure that we leave the board with a clear shared understanding. We do have very significant demands, as Gloria raised, around CAMS, both in our community service and our inpatient facilities, just to provide the board with some reassurance in terms of sending patients having to receive care in the private sector. It's patients with eating disorders, young people with eating disorders, and they are not receiving care out of areas, so they are receiving care within South West London, but through a private provider. We have got I'm pleased to say that a new facility has been opened at South West London and St George's. It's a repurposed ward that we managed to get rid of dormitories in, which is very good for children. But the challenge that we have is the staffing of that unit. So just, we are working with some of our units with 40 to 50% vacancy factors and having to use agency staff for that. And we have to counteract that with the balance of quality and the number of beds. And the reason I'm raising that is just that factor around resilience, really, and the impact for both young people and for staff.
Thank you, Vanessa. Ben, can I ask you to come back on the radar question from Mercy, and then Gloria, if you could come back on Ruth's questions about additional metrics, please.
You can, if I give you an overview of radar, and Gloria might want to come on the specifics of how quality using it. So radar is a system that we've built in to manage a number of our processes. So for example, we've started by bringing it into our complaints function. As a customer record management system to log all of the complaints and inquiries that we get and then produce a workflow from that. It also means that we'll be able to do much better analysis of the themes and the data that's coming out of that. As a part of that, we're also using it as well to manage our risks frameworks and automated risk system in the future. And we've been involving Gloria's team in linking that in because it has a specific element for serious incidents as well. And Gloria might like to say a bit more about that.
Thank you, Ben. I'm just going to come on the back of that to say the radar system itself, what we really want it to do is to be able to triangulate because at the end of the day, we have done this report individually, and it's about really having that system overview of what is going on across other areas, and then be able to pick up the key themes. However, what I will say is that what you said is right. We might need to bring a report here. Once it's well established, we are still at the early phase of it.
And then Ruth's question.
Ruth, thank you very much. I totally agree with you. I think we are developing quality as we go. What would be good is to have few other people in the room, maybe before the next board, and agree on which other metrics we can report on. But thank you. Thank you.
Thank you. Matthew.
Thank you, Chair. Just a quick question on radar. We're moving to radar at Croydon as well, and I just wonder how much consistency there is across South West London. I don't know, because if we were all using it, there might be some benefit in getting some connection and some themes because we're on the same platform. But I don't know. We're just in the process of implementing now, and it's going to be a few months before we're live. But that might be an opportunity.
That will be the future. That's what we really want to see, that every provider will use this radar in the future. But I think Croydon is going first, and we're going to be having discussion with other providers and see how far we get.
Thanks, Gloria. Ben, anything in addition?
I'll just build on what Gloria said. So our two teams are working very closely together, Matthew on doing it, and we've specifically tried to aligned the categories of reporting across the two systems so that we're not talking apples and pears, we are going to talk apples in the future. We're using sort of ourselves and linking out with Croydon as a bit of a pilot for this to see that see what we can get out of it. And as Gloria says, then hopefully this could be a platform that we can use in the future, and it is definitely a platform that we can expand and use in that way in the future.
Thank you. Ian.
Thank you, Chair. It's linked to the point that Ruth made, and so the report talks about CAMS and ADHD, speech and language therapy, etc. So the point's well made about the wider set of metrics. What I didn't get from the report, and the report's asking us to be assured with regards to action being taken, is that action. So I thought it's light on what we're going to do, who's doing it and by when. And I think we benefit the board from having a report back with the detail on what we're doing about these issues. Thank you, Chair.
Thank you, Ian. Gloria.
Just to say, most of the detail of this work are done at the subcommittee of this board, which is at the Quality and Oversight Committee, chaired by Mercy. And what we've brought here is just an overview and the key highlights. But if you want detailed reports, I'm happy to probably provide more.
Yeah, maybe it's a little bit of a sort of left-centre question, but I was wondering, we are about health and well-being of our people, but we increasingly have to be about health and well-being of our planet. And we have a tendency, I mean, it's COP27 and the world around us looks pretty messy. And what I don't want is that we park it because, now is not the right time. It has to be the right time, and we have to sweat where they're actually win-win solutions rather than pitting one crisis against the next. So I was wanting you to think a little bit whether we can weave it in so it becomes second nature.
I'm going to bring Helen in here as the sustainability lead.
Thank you. I think it's a very, very important topic, isn't it? It's very important that we do our part in this as we go forwards. And we're currently refreshing our approach to the Green Plan to make sure we do that. And it is key that we do this with everybody in our population and we empower them, because actually it's not just the power of what we can do at our own organisations, it's what we can do as a whole population, isn't it? So you're going to be a very important part of that as we go forwards, and we're looking to go to the ICP in January around updating on that and how we weave that through everything we're doing.
Thank you. Karen.
So Dagmar, you also know that we're working through with the Integrated Care Partnership, the work that we'll do across the whole of the healthcare and third sector. And we know that the Green Agenda is one of those areas that have come up through the needs assessment. So we'll also look through the ICP partnership, depending on how we continue to evaluate those and prioritise those, to make sure that isn't lost, that priority.
Thank you. So some things for you to reflect on, actions to take forward. I think in particular Ian's comment about how do we in this report ensure that the board gets assurance, I think is important to address moving forward. So if you could reflect further on that, that would be great. And with that in mind in terms of the actions that we've agreed, are we content to note the report? Thank you. Next report is the performance report. So I'm going to introduce Jonathan again, our Chief Operating Officer, who will talk us through the report.
Thank you very much, Ruth. So I've touched in some detail on urgent emergency care when we were talking about the challenges we faced this winter early in the meeting. So I wasn't going to recap on those, but obviously very happy to take any comments or questions people have. So just to draw out some of the other key messages in the report, obviously planned care and elective recovery is a crucial priority for us. We continue to make good progress on clearing long waiters for care, for access to elective care, and we keep moving that down through the cohorts, and we're now down to the sort of 52-week cohort and reviewing that in some detail. So that remains broadly on track and is well ahead of other parts of the capital, though of course still more to do, and some of that more to do is summarised perhaps most neatly in the statistic that our overall waiting list has grown by 19% over the course of the last 12 months. So whilst the tail of the curve is being cut significantly, the overall shape of the curve and some of the challenges in that remain very significant. I'd also point to diagnostics where despite us continuing to do significantly more work, there are areas of significant challenge, and they're differential by providers too. Some of the biggest challenge areas are non-obstetric ultrasound, endoscopy, and particular echocardiograms. And we're holding an event with the consultant cardiologists and other leads across the system next Thursday, together with the Acute Provider Collaborative, next Thursday evening to seek to find some ways forward in the particular issues we face around the echo pathway. So that's probably what I want to say on planned care, with the exception of talking about cancer performance. So the critical national measure at the moment is the 62-day backlog, so the absolute number of people waiting on that. Since this report was produced, we continue to make inroads in that area. So we're continuing to make good progress in reducing back to the original plan. We still have some way to go to get back to that plan, but we've made inroads from what you see in this report. Of course, it's good people are coming forward to get earlier diagnosis for cancer, but that generates its own challenges, of course, for the NHS in treating people in a timely way as referrals continue to increase, and we see that through a number of two-week wait pathways, skin, lower GI pathways and breast pathways probably being the most challenged in South West London at this point in time. So an area where things can change very rapidly by its very nature. The indicators only, the entire cohort should change every 62 days. So really important that we keep a firm and clear eye on that. And then probably the third area I mentioned was the challenges in the mental health space. There are areas of improvement, so early intervention in psychosis numbers are improving, which I think is a really important measure, but there are areas of ongoing challenge, so improving access to psychological therapies has been a challenge around workforce and a whole raft of issues for a while. Again, there's another meeting going on this afternoon trying to find a way forward to address some of those challenges that we face at this point in time. So in addition to urgent emergency care, those would be my other three probably areas to call out, Ruth, in terms of where we are at this point in time around our performance challenges.
Thank you. Mercy, anything to add as chair of the committee?
No, just to reassure the board that we at the QOC, we do have kind of regular updates on all these indicators. So we're looking at trends and making sure that we've got mitigations in place. But obviously we're getting our data from the system. So that's kind of really important. But I think we probably, by the time it gets to the board, I think it might be a few months delayed, but we see more up-to-date data. So I think that's for reassurance to the board.
Thank you, Mercy. Any questions, comments? Callie?
There's just a couple of things, if I may. So in terms of the cancer backlog, so the first thing, as Jonathan says, is rightly, it's really important that we get patients coming forward early because that makes a big difference to our ability to cure. And so referral levels are at an all-time high. They're around 130% of pre-pandemic levels. So this is, as Jonathan says, is a bit of a moving target to make sure we keep up, but nevertheless very important that we get people coming forward. So, and most of those waiting, so only about 6% of those in that 62-day pathway will have cancer. So it's good that people are coming forward. Secondly, this is about diagnostic capacity. And the additional information I just wanted to add, I've just seen a submission from RM Partners, our Cancer Alliance, and so Susan Sinclair, the Managing Director, is just about to submit a bid to NHS England for accessing some rare capital that's being made available to help with diagnostic capacity. Effectively, it's an underspend from the rollout of community diagnostic centres. So she's just putting in bids to the value of 6 million. So we'll see what happens in the next couple of weeks on that. So hopefully that'll give us a bit of support with capacity, particularly the diagnostic part of the pathway. Thank you.
Thank you. Lots of nodding around the room in support of that. Sarah?
Yeah, so diagnostics is one of the major issues that we have actually around this. I think also workforce is quite a major issue around the diagnostics as well. So capital is really great, and we definitely need that, but we also need to think differently about how we're going to transform the way we deliver those services, because actually there is a limited capacity within our workforce around some of these areas, and with the increase in referrals that we are seeing and the need for diagnostics, I mean, it's really good, as you say, that we are getting increases. This is one of the areas we definitely want the increases, but when you say only 6% have actually got cancer, then the faster we can get through those diagnostics, the faster people that have got cancer will receive the treatment that they need. So I do think we need to think very differently about this. I know that RMP are doing that, and actually we're very lucky, I think, in South West London to have RMP in the way in which we work across South West London, because we have historically been in a really good place around cancer, and I know we've had a bit of a dip, but that is coming back again now, which is really, really positive.
Thank you. Any other? Karen?
I just wonder if it's worth saying that we also got some additional funding from, I think it was Health Education England, to look at 2 areas of workforce, and diagnostics was one of those. So we'll have a look at what that is actually finding. That's probably still early days, but to try and begin to look at a different kind of workforce that would support diagnostics going forward.
Thank you. Matthew?
Thank you. Yeah, just a quick addition to the point on diagnostics. I mean, I think it is helpful that we're flagging it. There's a risk sometimes that it goes a little bit below the radar, particularly, less obvious testing like echoes. And if there was one area that I'd flag at the moment, which is looking increasingly challenging in every patch, even those where it looked like we might get some mutual aid by sharing across South West London, which we're looking to do as much as we can, that doesn't look like it's likely to deliver us the benefit that we want. So we're looking at insourcing and different ways of treating the patients, etc. So it's just worth highlighting it, that it's one of those things that people wouldn't immediately think about echoes being, but actually it's probably, from a diagnostics perspective, our biggest challenge and our toughest nut to crack at this moment.
Thank you. Noted, Matthew. No more questions or comments. So on the basis of the discussion that we've had and the additional points raised, are we content to note the report? Thank you. Moving on then to the final report. So this is the finance report. I'm going to ask Helen Jameson, our Chief Financial Officer, to talk us through the report. Helen.
Thank you, Chair. Happy to take any feedback on the report again as we continue to develop it and evolve it to make sure it is the best it can possibly be for the board. But I just wanted to start again to remind us that we are looking at two different budgets here really when I do the finance reporting. There is the internal ICB budget, which relates to the funds that are allocated to the system to spend on our local population. And then there is the South West London NHS system budget, which is the wider £5 billion that we spend within the system itself, recognising that other areas and other ICBs and specialist commissioning also buy services from our providers within this pact as well. So if I just start with the internal ICB budget, you will be able to see from the report that we are £14 million better than planned within the ICB, but that relates in the main to clawback of ERF, which is the additional funds we get for overperformance from activity levels of 1920. That is to ensure that that stays within the system and isn't lost to the system as a whole, but recognises that currently the providers across the system are not delivering to those levels that were originally set in the plan at the beginning of the year. And so when I come to the wider system report, you'll see that actually there's an equal and opposite £12 million on the other side. So that means that as an ICB, we're £2 million ahead of where we thought we would be at this point in year. And that does relate to non-recurrent savings coming out earlier than we expected them to be. But I just want to highlight a couple of pressures that are within that area, and that mainly relates to prescribing, where we're seeing inflationary increases and unavailability of some of the generic drugs, which means more expensive drugs need to be procured to be able to serve the population. Also around some of the some pressures within CHC, although we're doing very well, as Gloria said earlier, on doing that and managing that, and have managed that much better this year than potentially in previous years. So, but just wanted to highlight as a pressure. Just happy to say that actually we continue to make our investments against the NHS required levels for the mental health investment standard, which is really important that we continue to do that, and that we're continuing to deliver those efficiencies, obviously at an ICB level. If I then move on to the system level report, this is made up of the ICB and the NHS providers across the system. We were planning at this point in the year, at the end of September, to have a £59 million deficit, and we are £1.6 million adverse to that plan. So broadly in line with that as we go forwards. It's key to note that the largest challenge within that is our savings plan. So we set out with a £280 million savings plan at the beginning of the year. And at the time of writing this report, there was still £83 million that was unidentified as savings, although I'm happy to say that number does continue to come down and is lower now than it was, but obviously still remains the key challenge for us as a system to be able to deliver at a break-even position. Obviously, there are further challenges that have occurred since the plan was initially written, and that is around inflation and the cost of living crisis that we see now, around pay inflation, because the pay award was higher than that expected at the time of planning, etc. So it's key to note that those are in here, and a key area pulled out in the report is around that of workforce, noting that NHS England has set an agency threshold on the amount of money we should be spending on agency, and that we are currently exceeding that at this moment in time. Finally, I'd just like to move to the capital section of the report. So as a system, NHS England allocates down capital funding, a capital budget if you like, to be able to support our trusts in the system. This is split in two ways. It's a low-pool target that's set to allocated to us of around 128 million in this year, which is related to the critical infrastructure of those organisations and to be able to help and support them. And the other part of that is around the national pots, such as the one that Callie just described earlier, around the collaborative bidding for funds to be able to do and deliver stuff. Although we are behind at the moment on plan, we are still expecting to catch up by the end of the year and deliver that, and NHS England are happy with where we are in our planning and delivery, but happy to take any questions.
Any questions on the finance? Dick? Oh, sorry, Dick, I should have brought you in. My apologies. As chair of the committee, Dick, would you like to add anything to that report?
I just wanted to thank Helen and the team for another excellent report, but to reinforce Helen's remarks, I'm struck that our system budget is this is an area of really significant uncertainty and risk. The issue of the gap between 5% inflation assumptions and 10%, I haven't seen what the autumn statement says, but someone who's better on the laptop than me may already know there's another area. 30% of the efficiencies not still red rated within this system. And I would just highlight that the issue of agency costs, which interacts with all workforce costs, if anything, those costs are accelerating in the last six weeks. And NHS National Executive may put a cap on, but doesn't stop the tide coming in. So those challenges sit in front of us, and I'm struck that may shift what I know there's work going on right across the system to identify savings, but there's a certain level of challenge at which more imaginative redesigns and different ways of collaborating need to be thought of to get closer to balance, and that's quite a challenge for us in the new system where we're all every partner and the ICB obliged to help each other balance the books. So I'm just struck that this challenge is coming at us, and it could turn out to be really significant. Thank you.
Thank you. Sarah?
Firstly, I think the autumn statement's tomorrow, actually, Dick. But we all look forward to it, I'm sure. Yeah, I was going to say, Dick's got a direct line somewhere. On agency, I do think this is really important, and I think all providers do struggle with this because it is as been described to me, it's a buyer's market at the moment because we are really struggling with staffing, and particularly during the winter. But there is now a London-wide agreement around agency, around a kind of agency cap for London, which all providers have signed up to. So we hope that will make a difference. The problem that we have is that if people are paying differentially for their agency, and it might not even be in South West London because I think we have an agreement in South West London, but then you're in competition with people outside London, with people across London, and it's the same staff, we're all fishing in the same pond, so it's a really difficult thing. And I'm sure providers would say if you're running an A&E and you can't staff that A&E, you're in a really difficult position trying to just get staff in to deliver that. So it's difficult, I think, and we're not sort of saying that we don't have to put plans in place, but some of this is not easy stuff to deal with when we've got the workforce challenges that we've got. But I definitely agree on the transformation. It's what more can we do differently. The good thing for South West London is our productivity is increasing. So my understanding is that we are one of the areas where we are becoming more productive throughout the year. So we are making efficiency savings, but they're just not yet, and maybe won't be, and that's the discussion that we will have to have at the level that we need them to be in order to get to a balanced position. So that's going to be our challenge going forwards, and I think probably one of the providers, particularly Joe by the looks of it, might want to say something on that.
Joe, I'm going to bring you in.
Oh yeah, I guess it wasn't on that, and I think you're right, Dick. Challenging is probably a bit of an understatement as to what lies ahead. I think the thing for me in all of this, and we've been talking about it both internally within my organisations, but also in the places, despite what lies ahead, we need to try and protect the money that's going to help us think about the preventative agenda and doing things differently, which will pay the NHS dividend in sort of 5-10 years' time. I think when the pressure really gets on, there's a temptation to stop the things that you can't immediately sort of attribute a return on investment to, but they are absolutely the things that will not only get us through this immediate bit of challenge, but also stand us in better stead for the future. So I think somehow, despite what does lie ahead, we need to make sure we stay disciplined and make sure we're at least spending some of our resources on changing things and think about how we can support each other to work differently.
Thank you, and I think an important for the future. Annette.
Thank you, Chair. I just wanted to firstly agree with what Dick and what Joe said, and I think also just to highlight that in primary care we're also facing some workforce cost challenges in that locum rates are going through the ceiling, quite frankly, and I think as winter comes along and we have sickness within our own workforce, that it's just to highlight that will put a significant financial pressure on primary care, and I just really wanted to highlight that. I think we I completely understand the pressures in all the other part of the system, but I think just to highlight primary care as well.
Thank you. One comment and then a question from me. So I don't think we're just fishing in our own pool. I think there are lots of things happening outside the pools and people are fishing in our pools now. You'll see what quite a lot of employers are doing in private sector to respond to cost of living, and they will be attractive packages for people, particularly when they're under cost of living pressures and are worried about food and energy. So I think it's important to recognise that we're not just our own ecosystem, but connecting more and more with other employers, and the war for staff goes beyond our own pools. And then, Helen, there is a rather scary graph on page 11 of the report, and scary because of the divergence between the total staff plan and the actuals. Can you just clarify? I think that is because of the pay award.
On the cost part of that pay award.
Yeah.
Significant movement.
Yeah. And yeah. But would you expect those lines to come closer together?
Yeah, I think maybe what we'll do is we'll try and normalise it for the pay award next time so that you can see the actual movement rather than just the pay award movement.
That's great. Yeah. Thank you. Otherwise, it does look really worrying. It looks worrying.
But it got your attention. So
it got my attention. It definitely got my attention, Helen. I would definitely say that.
So I did what I aimed to do. That's good.
Yeah, exactly. Any further comments or questions, Nicola?
Thank you. Helen, can I just ask you about the prescribing issue?
Yeah.
So just for clarification, are you talking about the primary care prescribing budget?
Yes.
Yeah. Okay. So I thought so. I just wanted to flag really that I think it's really important that we don't look at prescribing sort of as a budget line on its own, because of course if you put people on the right drugs, even if they're expensive, then it helps them manage their condition, it improves health, and it keeps people out of hospital. And so there's you can't just look at prescribing, and I know you won't be. Just a real practical thing really is the impact of some of these strange things that are happening in the system with drug shortages have a real impact on community pharmacy actually. And how things are managed there, so to take that into consideration as well. And also the interface between primary care prescribing and prescribing elsewhere in the system, it's not just an interface actually, drugs move across from one to the other. There are issues for our workforce in just managing back the clinicians, but also the costs in the different systems, and also new drugs coming along which are expensive and necessary and important, and where they're prescribed. There isn't any shift between the prescribing budgets, if you see what I mean, any practical shift of money between the two, and we sort of need to look at that holistically, and I hope that's something we'll be able to work towards.
I'm just going to bring Mark in, and then Helen, I'll come back to you to respond. Mark.
I suppose it's just on the ICB budget, particularly around continuing healthcare, and to provide assurance, just in terms of Ian, that underneath that figure there is local plans to mitigate or contain CHC spend.
Thank you. John, did you also want to come in?
Can I just pick up the comment about prescribing spends, if that's okay? So at the last Finance Committee, under Dick, there was a conversation about some of those pressures which were articulated in a little bit more detail that might just come across here. And there was that acknowledgement that there's really strong benchmarking data showing the good work that's happening not just in South West London but right across all the boroughs in South West London. So we compare really well compared to the London picture but also the national picture in terms of prescribing spend. So I think that is understood, and what we're articulating here is there's some pressures and demands which might be outside of our control. However, that doesn't mean to say that there isn't always opportunities to look again at some of the things that we're doing, and I think most people clinically would, in terms of clinical stewardship, would acknowledge that's an ongoing part of our job to do. So while we are in a very strong position due to lots of great work historically, that doesn't mean to say there aren't pressures, and some things we can fix and some things we can't. So I don't see it from a blaming primary care or secondary care or mental health in terms of the drug spend. Some things are just beyond their control, and I think in fairness to the Finance Committee that was captured in that way.
Thank you, John. I think I completely understand what you're saying, and I completely recognise that picture you described, Nicola. I think this was purely about trying to highlight some of that inflationary pressure that's there, that's, as John said, completely beyond our control. But I do know that our Medicines Management Committee is looking at this and how that fits together and where it's going, so that we have that overview and what we can do, as John's just described. So.
Thank you. I'll give final word to Sarah. Thank you.
So John's going to love me for this, but this is an opportunity, isn't it, around prescribing, because I think we've kind of done it in a certain way, which is we've worked with primary care, which we need to do, but I think what is our system response to prescribing around working with trusts and others in a slightly different way going forward. So I think as an ICB, there's an opportunity, with John as our lead, to think about what could we do in a more integrated way with our colleagues across the system, the clinicians across the system, not just in primary care, and how do we make a real difference by integrating that in a way that makes sense. And I definitely know that John is looking at that for us, and we'll have a think about how we work with everyone across the system, because I think that's probably been a gap, and this is an opportunity.
Thank you, Sarah. So noting the discussion and the comments, is the board content to note the report from the Finance Committee? Thank you. So, final thing under item 11, we've got 3 committee updates from the Finance and Planning Committee, Quality and Oversight Committee, Remuneration and Nominations Committee. These are for information only and not for discussion. So no decisions required. Moving on to item 12. So these are questions from the voluntary sector and Health Watch. Unfortunately, Simon Breeze was unable to attend today, but he has provided some questions to Ben. So Ben, could I ask you to read out those questions, please? And I believe Charlotte's going to respond to those questions, and then Liz, I'll bring you in for your questions. Thank you.
Thank you, Ruth. So this refers back to item 9, so the item on the People, Communities and Engagement Assurance Group. Simon says the VCS very much supports co-production, but this also always starts with senior officials giving up decisions on power and resources to the community. However well-intentioned co-production cannot work without this. We're very happy to see the reference to involving the VCS in engagement and co-production. However, there needs to be an awareness that while most charities exist to support and advocate for their beneficiaries, that they do not have the resources specifically to support statutory engagement. Even small amounts of funding to support such engagement activity goes a long way and allows small organisations to cover their costs. Engagement without this risks adding strain on the VCS and diverting resources away from core activity. If there is commitment to working with the VCS organisations on engagement, this needs to be supported with funding.
Charlotte.
So I think what we will say to Simon, and we can talk to him afterwards, is that we absolutely recognise the pressure the voluntary sector has been under, particularly in recent years, and that they have gone above and beyond to support the NHS and our efforts. And I think we do accept the need for funding, and indeed we have funded the South West London Voluntary Sector Alliance post to help voluntary sector work together more closely, and indeed the street ambassadors I mentioned before for the vaccine programme. Again, we have funded through the voluntary sector, and the investment fund opportunities. Again, we've made an effort, and we need to obviously think about how we do that going forward. But again, that is about kind of funding the voluntary sector. But I suppose the point more broadly is I think me personally, I have been on a journey about my understanding about the voluntary sector, and I think as the NHS, we're all on that journey to understand the voluntary sector better so we can work together better. And I think, particularly I have a lot of voluntary sector colleagues say to me that people think the voluntary sector is volunteers, and there's a lot of conversations about should we start calling the voluntary sector charity so that people understand it's not just people volunteering, they're actually providers of services. So I think we do need to kind of work more closely together. We will make mistakes and we will get it wrong, but I think all our intentions are good to kind of make sure we improve the way we do things.
Thank you, and thank you to Simon for those questions. Liz, have you got any other questions on the agenda?
Thanks. Yes, I've got a couple of questions relating to the discussion on item 10. the first of which relates to the quality report. And I wasn't sure whether the point that Ian Thomas raised about having information on what actions would be taken on particular issues, whether that point was accepted and kind of built into the future reporting. So, do you want me to take the second point or leave a gap?
So I'll just quickly come back on that to say that at the end of that item I asked Gloria and Mercy to reflect on the comments that Ian had made so we could think about how we can ensure that the future report that came back provided that level of assurance. So I think we did take into account Ian's point.
Thank you. And the other question relates to the discussion coming out from the performance report about, particularly about cancer referral and about imaging. And I picked up in the press this morning that there is a new development where GPs will be able to refer patients with non-specific symptoms, such as fatigue, straight into the system to have scans rather than needing to go via a specialist. And, I was wondering, not necessarily in the meeting, but, perhaps as some thoughts afterwards, quite how that will work locally.
Thank you. Kelly, do you want to respond to that? Thank you.
So there are two pieces of work. One is about ensuring GPs have direct access to the new community diagnostic centres so you can directly commission rather than work through acute trusts. So there's a piece of work going on in the National Cancer Programme to enable that. And then I think the second issue is that for many patients, they bounce around in the system if they don't have obvious signs and symptoms, but something's not right, weight loss, breathlessness. And so we are rolling out non-symptom specific pathways with primary care throughout the NHS. And that is to make sure patients can get on. It's easier for primary care colleagues to put the patient on the right pathway to have the tests wrapped around the patient rather than going for each test in a sort of bilateral way, which holds them up and is very, creates a lot of uncertainty for patients going through the pathway. So there's two initiatives going on nationally in cancer that should improve the pathway for patients with the support of primary care colleagues.
Thank you. I'm just going to also ask Jonathan to come in.
Yes, it's a well-made point, Liz, because I also saw that on the front of some of the newspapers this morning. I think the honest answer is we probably need to do some work locally to model through some of the consequences of that for community diagnostic centres, through the diagnostic board, the Matthew chairs, through work with RMP and indeed with primary care colleagues, where some of these direct access services have been in place historically. So I think it's a well-made point. It's new news, as it were, to us in terms of exactly how it's going to operate, and we'll be working it through over the coming weeks and months so that we plan services that deliver what Callie has described, which is obviously crucial to earlier diagnosis of patients, given how far this country lags behind some other developed nations around that.
Thank you. Sorry, Annette.
Just wanted to come back to Liz as well to say that we have one of those clinics in Kingston, Liz, for non-specific symptoms. So we have been able to refer patients into that for about the last 6 months, I think, in fact. And it's been, as far as I understand, really successful. And it certainly has been very welcome to GPs. So we can get some information for you about the outcomes from that.
Thank you. So just for the benefit of members of the public, I'm just going to do any other business, close the meeting, and then I'll come on to the public questions. So item 13, any other business? No, I've just got 2 items of any other business, so 2 thank yous. First of all to Ian for hosting us in this fantastic room today. I'm not sure those people that are seeing this on video will be able to see how fantastic this room is, but thank you very much for hosting the Integrated Care Board. Fantastic, thank you for that. And then finally a thank you to Liz So recognising that this is probably your final meeting, given that we'll have another representative from Health Watch, but I just wanted to pass on our appreciation for the contribution that you've made to the Integrated Care Board, and wish you well. I'm sure you'll continue to be a friend and a challenger of what we do, but thank you for your contribution. So with that in mind, I'm going to officially close the meeting and I'm going to move on to public questions. So I know that we've got a question from one member of the public. We've also got one written question, so I'll take the written question first and then I'll come to members of public in the audience. So our first written question is a question received from Kate Box. Just checking Kate isn't in the audience, just in case she wants to ask the question herself. No? Okay, so I'll read out her question and then come to John, if I may, to respond. Kate says, I have type 1 diabetes, and despite the nice guidelines of offering all T1Ds access to glucose monitoring technology coming into effect in March 2022, I only received flash monitoring yesterday as of the 8th of November. At my appointment, I asked if I could begin using a CGM Dexcom 1, given it costs the same as a Freestyle Libre 2 and in my eyes is far superior. I was told that this wasn't possible as the board is yet to make a decision on introducing CGMs for all T1Ds in the area. My question is twofold. Firstly, when do you plan on introducing CGMs for all T1Ds on prescription, given the cost equivalence with Flash? And then secondly, why, despite most of NHS England introducing CGMs, has South West London still not done so? John, can I come to you to respond, please?
So thank you. It's a great question in many ways because it highlights some of the challenges that we've got. So on Monday, I'm not sure if all board members are aware, was World Diabetes Day, so it's probably apt that we have a conversation about diabetes today. And NHS England produced a new piece of work based on how we support people with diabetes, which is based on increasing the levels of peer support. So it's recognised that if you get self-management right, you need decent peer support and you also need access to services. So I just want to reiterate the broader picture around diabetes, particularly type 1, and the work that's going on. To answer the specific questions, we do use continuous glucose monitoring devices in South West London. The team have told me that there's several hundred people on these devices. We've followed a One London approach in terms of how we use these devices, so the people who are getting continuous glucose monitoring are in line with a clinical policy supported and designed by London. The second point Kate raises relates to the fact that there's been a shift in device costs. So the latest device, Dexcom, has come down in price and we acknowledge that. So currently we're assessing through the Integrated Medicines Optimisation Committee. That's a bit of a word mouthful, but we're looking at that to see what that means in the context of residents of South West London. But just want to bring it back to the conversation we had about finance and performance and the cost pressures, and just making sure that actually when we do make a change, we understand what the implications are, not just for people with type 1 diabetes, but funding across the general system. So we've also had a look at data in terms of people who are actually getting access to glucose monitoring. We're doing quite well in that with South West London, but more work to do. So I'm confident that we're on the right path, but at this point I don't have an answer as to if or when we would actually go down the continuous glucose monitoring route for everyone with type diabetes, and we'll just wait for the expert view locally on that, but just to say it is just national guidance at the moment.
Thank you. In that response, we'll go back to Kate, I believe, in response to the email. Thank you. Could I now take any questions from members of the public? I believe we've got one member of the public who's had their hand up. I think we're going to give you a roving mic. And please do introduce yourself and ask your question.
My name's Wendy Micklewright, and I'm involved with the Hearing Voices Network. I hallucinate, I hear voices, but I'm not ill and I don't take psychiatric drugs. The World Health Organization, which was mentioned by Mercy earlier, wrote a report calling for global radical change to the mental health system. And there's two books I would draw your attention to by James Davies. One, Cracked, Why Psychiatrists Do More Harm Than Good, and the second one sedated how modern capitalism created the mental health crisis. There's also something I've mentioned in the past repeatedly, which is known as the Wigan deal, and the people involved with that have now written a new report. Then they're called New Local, which is a community-powered NHS. So these things need to be considered. And I know that in some parts of London they have what's known as a health and care people's assembly, because I think what happens is that these meetings aren't really relevant to a lot of people. So I think that you should seriously think about people assemblies, like the ones that I think they're happening in Islington. The other thing is that in Manchester they did some research and they found out that 80% of people on mental health wards were in fact homeless. So I didn't hear anything about housing here really, apart from reference to homelessness. So there really is a problem in housing. And I would suggest that you talk to your colleagues in local government about community land trusts, because affordable housing isn't affordable. And why should people have to pay rent all their lives? And it has a huge impact on older people. And last but not least, we have collected information using the Freedom of Information Act, with a focus moving away from paternalism to human rights. It's well-respected work by Frank Keating, and we've gathered the information over many years across London. Like many organisations, we don't get all the information from all the people we ask from it, but it is a little bit disappointing that South West London St George's hasn't responded to our request. But if we look at ECT, for example, which is what this is about, and there are people in this room who've been involved with the Wandsworth Community Empowerment Network, and when I raised ECT at their meeting, there were people very brave people who stood up and said what they thought about ECT and how it's just not acceptable in the society we live in, and it needs to stop now. And the research that we've done, although the chief medical officer I was talking to earlier says it's disputable and there can be the same truths in different areas, I'd ask people to seriously think about electroconvulsive treatment. And based on the Freedom of Information Act, it looks like it's a sexist practice. And I don't want to put Vanessa under pressure, but I think we know that the mental health system is racist, really, or I don't know how else to say it. There's a disproportionate number of people of the global majority in the mental health system. So I'll leave it at that, I think. Thank you.
Thank you, Wendy. A number of important issues that you've raised there. I'm just going to come to Sarah first, and then I think Sarah will bring in
I'll bring in some different people.
Yeah.
So firstly, yes, on housing, absolutely. We want to, it's one of the areas actually that came up in our integrated care partnership as an area that we want to focus on, and we do actually have quite a lot of work going on homelessness across South West London, but I think it is an area, and I think it's rightly raised, Wendy, so thank you very much for that. I'm going to come to Charlotte on the issue of a people assembly, and then I'm going to come to Vanessa on the mental health issues, if that's okay. Charlotte.
Yeah, so maybe we can talk afterwards, Wendy, because we are sort of thinking about how we engage with local communities, but at a place level, because we think that's where the good conversations happen, rather than having a kind of South West London People's Assembly. We do have a South West London People's Panel with over 3,000 people on it, but in Kingston particularly, so Hannah, our engagement lead for Kingston is here, we're kind of rethinking what we do in Kingston, for example, about a kind of people's forum, so maybe we have a chat afterwards. Richmond too, so we can come and talk to you about that.
Thank you, and Vanessa.
Thank you. Thanks, Wendy, for your thoughtful and respectful way in which you raised your points. I really appreciate that. I agree with you that housing is important, as is employment to people's mental health and well-being. So continuing to advocate that we have those conversations, I think, is entirely the right thing to do. In relation to the engagement element, I just wanted to also raise that we're currently completing the South West London mental health strategy. I'm very much hoping, I know that many people in Richmond and as all 6 boroughs been involved in that, but as we bring that to kind of, not conclusion, but to bring it together, it would be also great to have your input and the input of those that you have contact with involved in that. I think you raise a really important point around access to mental health services, particularly for those from Black and ethnic minority communities. We know that our system, not just in South West London, but across the country, a disproportionate number of Black people are detained under the Mental Health Act, and they don't have the same access. And when Jonathan was talking earlier about access to psychological therapies, we know that more women access our psychological therapies than men, for example, from Black backgrounds. I can't comment on the numbers of women and men in relation to ECT, but I can find that information out, and I know that we have ongoing conversations about FOI requests, and we'll continue to do so. Okay.
Thank you. I'm just going to check that there's no more questions from any other members of the public. Okay, final thing to thank everybody for their contribution and time today. And I believe we have finished 10 minutes early, not too smug. Thanks very much, everybody. Take care.